welcome back to Science of Medicine. Today I want to talk to you about some useful mathematical tools that are used in medicine. Before I do that, I want to let you know that medical measurements are made using both old-fashioned types of units as well as more recent ones. For example, sometimes masses are in kilograms or milligrams or even grams. Volumes are in liters, but sometimes the volumes are expressed in deciliters, something which is not very often used in normal control. So that means that we can express concentrations or the amounts of those medicines or whatever we're talking about in terms of a mass volume like milligrams per deciliter, or we can do it as a chemist would as particles like millimoles or moles per liter. And another way of doing this concentration expression, particularly for microbiology applications, are in titers. Now, titers are a dilutional method, and they're typically used for determining the minimum inhibitory concentration of bacteria. And the way that this experiment is done is that you would grow the bacteria on a plate, and then once you've grown that bacteria, you would place small discs that would be impregnated with an antibiotic, and that antibiotic would then cause the retardation or not the growth visibly of those bacteria, and the minimum concentration of antibiotic that disc was impregnated with is referred to as the minimum inhibitory concentration. So therefore, a titer that is 1 to 32 is killing or inhibiting growth of those bacteria at a much lower concentration than something that would be at 1 to 8. So in general, that lower the MIC, then the better the antimicrobial agent is at retarding the growth of that bacteria. So let's use this as an example. Let's say a person is in a nursing home and they have signs of an infection. Just as an aside, the fact that you grow bacteria in the urine is not in and of itself a sign of infection. But let's say that this person was showing other signs of infection, and in doing so, this grew out a very typical kind of bacterium for infection called E. coli. The lab will then do antibiotic sensitivity testing, and that's shown in this table. So you have to select which antibiotic is going to be used for treating this. And there are several considerations in doing this. Number one, the medication that you give to the patient has to be something that they can tolerate, that they're not allergic to, or that their kidney function will allow. It also has to be in a form that they're easily able to take it. So for example, oral versus intravenous versus intramuscular. And you want it to be the most effective drug for actually doing the job, that is killing the bacteria. So here are an example of 4 drugs, macrobid or nitrofurantoin, ciprofloxacin, Keflex, and amikacin. And my question is, which antibiotic would be best for treating this infection if the patient can only take an oral medication? Now, the lab doesn't know whether or not they're going to take an oral medication, so they will report a variety of antibiotics and the susceptibility. So you have to look and say, oh, only 3 of those 4 possibilities are oral, so I'm going to eliminate amikacin simply because it's not available to me in pill form. And then the next thing I want to do, I don't have any antibiotics or any other concerns that were expressed, so the next thing that I want to do is look at the MIC. And I see that macrobid has the lowest MIC, 1 to 16. And so consequently, that's going to be the most efficacious medication for me in this example. Sometimes people will need to do conversions between one thing and another, and I wanted to show you about how that is done. So in this case, I have a 78-year-old woman who wishes to begin calcium supplementation to prevent osteoporosis. and she chooses calcium carbonate. There are several types of calcium supplements that are on the market. Obviously, it's not elemental calcium, and this is what she chooses. That has a molar mass of 100.09 grams per mole. Now, although the current literature doesn't support a particular level of supplementation, there has been harm found when the amount of supplemental elemental calcium exceeds 1,200 milligrams per day. And so if the patient currently estimates that her daily intake of elemental calcium is 400 milligrams a day, and the maximum is 1,200, what's the maximum amount of calcium carbonate supplement that she should take to not exceed that guideline? And so this is something which happens a lot. A patient will come in, they'll have some sort of an over-the-counter medication or supplement, and they'll want your advice on this. So this has to involve a conversion. It has to involve a conversion because the person is not taking elemental calcium, she's taking calcium carbonate as a supplement. But the guidance is in terms of elemental calcium. So you have to convert between the elemental calcium and the calcium carbonate that she has done. And this is why all physicians have taken a year of, at least 1 year of general chemistry. So in this case, you have to recognize that you want that maximum amount of calcium carbonate, and you have a restriction based on elemental calcium, and you have to do a conversion. So I know that the maximum amount of elemental calcium that I need is 800 milligrams of elemental calcium, and that's because she's already taking 400, and 1,200 is my upper limit. So I can convert that elemental calcium into millimoles of calcium. And I know from the formula of calcium carbonate that there's 1 millimole of calcium carbonate for every 1 millimole of calcium. So that's where I can link this calcium to calcium carbonate. It goes back to that formula. And then I can convert that millimole of calcium carbonate into milligrams and give her that guidance. Let's talk about another type of very common application that involves infusions. So in this example, a patient that weighs 85 kilograms has what's called pulmonary hypertension. That's like a high blood pressure in the lung vessels. And they're admitted to the intensive care unit and treated with an intravenous drug. You wish to infuse the drug beginning at a rate of 2 nanograms per kilogram of patient weight per minute and increase it to a rate of 8 nanograms per kilogram per minute. And this would be from a protocol that you might have. Now the pharmacy actually will supply you with this medication, with this drug, and it's made up of a concentration of 0.5 milligrams of the drug per 50 milliliters. But you have to figure out what rate in milliliters per hour do I put into my order so that I can have this for my initial infusion. Because you have to actually give that information. So there's a number of conversions that need to be done in terms of this. And so let's walk through that process. So the first thing is that I'm starting with an initial rate. I am starting with that 2 nanograms per kilogram. And that's where this is coming from. Now, many times, a lot of medications are dosed per mass of body weight, and that's what this 85 kilogram is for. But now I have it in terms of nanograms, and I need to convert this into something that I have as a little bit more tractable, because my concentration of my solution is in milligrams per milliliter. And so I need to convert my nanograms into milligrams. So I can do that by converting it to grams and then converting it back to milligrams. And then the linkage between mass and volume, in order to get this rate, is based on that concentration. Because it's a convenient way of dispensing an amount, a mass, is to make a solution of that mass and then dispense it as a volume. And then I can convert it into hours because that's the rate that I wanted to do, and I'll wind up with, this is my order. I'll order a milliliter of this drug per hour as my initial infusion. and then I can titrate it up. Now sometimes people will need to know something about bacteria or abnormal cellular growth, such as in cancers. And those are first order processes. And by that I mean that this differential equation is linked directly to the concentration of that particular thing, in this case a bacterium, with a rate constant K. I could separate this first order differential equation into two parts and integrate it between bounds of t equaling 0 to t and n going from n0, some initial amount, to some n after a time t, and I'll get this equation for exponential growth. It's very common exponential growth. Now, bacteria don't continue to grow at this rate because eventually they'll they'll actually grow so fast that they won't have enough nutrients to sustain the colony, and then they'll start to die off. But in the exponential growth phase, this describes it. So let's say, for example, that a person is having a hip prosthetic and it's accidentally inoculated with a bacterium that is very commonly found on the skin, the Staphylococcus epidermidis. And if this growth rate of this bacteria is 0.1 per hour, how long will it take for my colony to double in size, going from 1,000 to 2,000? So I can actually go back and use my formula. I can either put in 1,000 here and 2,000 here, or I can put in n0 versus 2n. When I do that and I make this linearized by taking the log of both sides, I wind up with a time which is about 7 hours, 6.93, which is just basically the log of that 2 divided by 0.1. And so this is something that on a daily basis clinicians don't do, but it does explain about very rapid growth. And so some things have rate constants, bacteria, that are very, very high. And it doesn't take long before they become clinically apparent as an infection. And one of the most common ways that physicians will use mathematical tools is through the use of statistics. And all of the studies that we talked about earlier will have results that will be reported in some statistical fashion. So I want to walk through and give you an understanding of how that's done. Before I do that, I want to make sure that you understand a couple very simple concepts. The first is the accuracy of a measurement. Now, the accuracy is referring to a nearness of a measurement, or really a group of measurements, to some accepted value. Again, science being non-falsifiable, it can't be true. That's why I put it in quotation marks. A lot of times what happens is people will get together and they will agree that when you analyze this particular sample 3 different ways and the value is this, that's what we're going to consider to be the value. And uncertainty in this is expressed in terms of error. That is, if my set of measurements disagrees from what is the accepted value, then I say that there's an error in my measurement. And it's going to be off in some direction. And it can be compensated for by various controls in your experiment. Now, precision is a concept that has to do with the reproducibility of values from replicate measurements. So I'm measuring the same thing over and over and over. And the reason that I do this is that if I don't have any systemic errors leading to a problem with accuracy, the precision is what is defining accuracy in this measurement. Now, as I mentioned, I can have errors that are in some particular direction. These are systemic errors or systematic errors, and I can take these into account and correct for them with proper control of my experiment. The random errors, the ones that result from simply making physical measurements by themselves, are equally likely to be positive and negative, and we model these using statistics. And I have measures that are used in statistics. The mean is 1. For example, if I look at the values that tend to fluctuate over 10 different replicate measurements, they will tend to fluctuate about some mean. I can calculate that by summing up all those values and dividing it by the number of measurements. I can calculate a measure of dispersion, and this dispersion is for a Gaussian distribution. Now, Gaussian distributions apply very broadly to measurements that are made of real numbers. They can either be positive or negative. They can either be whole numbers or partial numbers. And that's given by standard deviation. In both the mean and the standard deviation, I've used the Greek, which means that I have a large number of values. Technically, this is n-1 because I've used up a degree of freedom in describing the mean. But for large n, we say that this is n-1 is about the same as n. So if I look at a picture of different Gaussian distributions, I have something that might look like this. If you focus on the blue and the red and the orange curves, they all have the same mean, this chi value of 0. All right? But they have different dispersions, different widths of those peaks. And so in this case, the standard deviation of the blue is less than the red, which is less than the orange. On the other hand, the distribution that is green is one that has a different mean. Perhaps it has a systematic error that is shifted at some amount, and it also has a dispersion. Now, if I look at the area under any Gaussian curve around the mean, I can calculate the area under any different segment. And in fact, I could actually do this by integrating the function for this Gaussian distribution. That turns out to be a little bit more difficult. And so typically people will use tables. But for every Gaussian distribution, within one standard deviation of the mean, the area under that curve is 68.2%. If I extend out to 2 standard deviations, then it's just about 95%. And if I go out another 3 standard deviations, then I'm at 99.8% of the area under this curve. All right, so how do I actually deal with this significance in Gaussian distribution curves as it relates to medicine? Now remember, I said before that all hypotheses have to be falsifiable. And because a hypothesis has to be falsifiable, I can't demonstrate that it is true. But I can make a null hypothesis, and when I make this null hypothesis, I can show this to be false. And furthermore, I can estimate my error in doing that. And that's what the statistical significance is. It's a mathematical evaluation of whether some sets of observations reflect a pattern, my hypothesis, these 2 drugs work differently, or random chance. That's my null hypothesis, that they're the same. And typically what I will do is I'll have some control or a placebo and an experimental group. And because I can never be assured that there is a difference between these 2 variables, I'm going to estimate the error when that is associated with there not being a difference between them. So I have 2 types of errors that can result from this. So a type 1 error is when I reject a true null hypothesis. It's like a false positive result. I'm saying that something is true when it's not. Typically, this alpha error is denoted to be 0.05. That means that scientists accept that they're going to be wrong 5% of the time. And this is sometimes referred to as a p-level, or the level of significance of this. Now, I could calculate what my p-value is, and let's say it's 0.001, and that would be less than 5%. And so consequently, it would be significant given the accepted 5% error rate that is given. Another way of framing this alpha error is to say that I'm 95% confident that this is correct. And so sometimes you'll have a confidence interval, which will be at the 95th, the upper and the lower limit. Now, a type 2 error is if I fail to reject a false null hypothesis. So I'm saying that it's not true, but it really is. This beta error is going to be larger than this alpha error, and typically it's going to be around 20%. And I'm going to go ahead and then from this estimate what the power of my study is. All right, so let's talk about an application clinically. So let's say a study is undertaken to evaluate the use of fasting blood glucose measurements in the diagnosis of diabetes mellitus, my DM. 2 large cohorts of patients are examined. The first group, about 10,000 people, contains patients who have signs and symptoms of diabetes mellitus. And we will assume that they have a diagnosis of diabetes mellitus. And when I measure fasting blood glucose measurements for these patients, I get a mean blood glucose of 150 milligrams per deciliter with a standard deviation of 28.2 milligrams per deciliter. The second group, also about 10,000 patients, is made up of patients who do not have signs or symptoms of diabetes mellitus, and we will assume that they do not have a diagnosis of this diabetes mellitus. Their fasting blood glucose measurements average 90 milligrams per deciliter with a standard deviation of 21.9. So my hypothesis is that patients with diabetes mellitus will have a higher fasting blood glucose than those who are not diabetic. So my null hypothesis will be that there'll be no difference in the fasting blood glucose levels of those with and without diabetes mellitus. So if I take a look at this pictorially, I might show this red curve as illustrating the distribution of blood glucose values for people that don't have signs of diabetes mellitus. The average is 90 and the width is, as I said, for the standard deviation. On the other hand, this black distribution is for people that would have signs of diabetes mellitus. The mean blood glucose there is 150 milligrams per deciliter. So my null hypothesis is that there's no difference between these fasting blood glucose readings. Now, if I make that null hypothesis and I try to demonstrate whether it's true or not, I need to figure out what blood glucose value corresponds to an area on this curve, which are my normals, or presumed to be my normals, that corresponds to this area of 5%. That is, I'm willing to accept that I'm going to be wrong if the blood glucose is higher, is up here. And you can do those calculations. I don't show you how to do them in this particular video, but you can do those calculations. And when you do that, it turns out that for these numbers, it's 126 milligrams per deciliter. And that's currently what is used as our blood glucose diagnostic criteria. Now, once you've determined that, then you'll have an error of type 2, which is the beta error, and you'll get this area, which may be around 20%. It may be a little bit larger. It depends on how big this distribution is, how close these distributions are to each other. And the question really becomes, you know, what is the power, which is the white area over here? What is the power of that study given this blood glucose value and the area for this curve? So let's use this. Let's go ahead and use this in understanding different types of scientific studies. So this is a very important study. It turns out that patients that have an irregular heartbeat, which is called atrial fibrillation, are at increased risk of having a clot form in the left atrial appendage of their heart. And when this clot forms, it can break off, or pieces of it can break off and go to various locations. One of the locations it can go to is the brain, and that can cause an ischemic stroke. It's a very high risk, actually, and clinicians use a scoring system called the CHADS-VAS score that estimates the risk, but it can be up around as high as 12%, if this number is very, very high, per year. So that means that if a person had a CHADS-VAS risk of 10% a year, that person is likely going to have a stroke over a 10-year period. And so this became a real issue, and so we had to have some way of preventing clot from forming. And so the drug that we used was warfarin. And that has been used for a long, long time. Warfarin actually is a medication that inhibits the formation of some of the factors necessary for clotting. And so several years ago, there was a different type of drug, Pradaxa or dabigatran, which worked a little differently for making it so that you would not form a clot. And so in this particular trial, it was comparing this drug Pradaxa with warfarin, which was the standard of care. Now, in this case, it would not be ethical for you to give a person placebo because the risk of them having a stroke would be very high, and you already have a medicine that has been shown to be effective in trying to minimize that risk. So you hypothesize, if you're the company that's making this, that in patients with atrial fibrillation, treatment with the Pradaxa will be associated with fewer ischemic strokes than those treated with warfarin. And then the null hypothesis is that there will be no difference in the number of ischemic strokes in patients treated with Pradaxa versus warfarin. So now you need to do your experiment. You do, let's say, a randomized clinical trial. You could blind it or not, but in this case, you just randomize them, where you would have people with equal risks of an ischemic stroke based on that CHA2DS2-VASc score. Group 1 is going to be people that are given Pradaxa, and Group 2 would be warfarin. You're going to then give them either of these medications, these are the intervention, and you're going to measure the number of ischemic strokes in each group. That's your endpoint, your primary endpoint. Now, there are several different ways that you can actually report data. For things such as clinical trials and cohort studies, those are prospective studies, we tend to use a relative risk. Now, a relative risk means that the incidence of whatever you are looking for, in our case, ischemic stroke, with exposure, in this case with the drug Pradaxa, versus the incidence of that ischemic stroke with warfarin. And if the relative risk is 1, it means that the outcome, ischemic stroke, is equally likely with those two medications. If it's less than 1, it means that the drug that you're testing, in this case Pradaxa, is less likely to produce that undesirable side effect of ischemic stroke. And if it's greater than 1, then it's more likely. So people frame this in 2 different ways, and I want you to understand both ways of framing it. Let's say that you calculate a relative risk and it's 3.5. What that means is that it's 3.5 times more likely to have that outcome with whatever you're doing, the exposure or the drug, relative to not having it. So one way is to do it so many more times. The other is to say that there's an increase in a percentage. Now, if you went from 1 to 3.5, that's a 250% increase. So 1 to 3.5, the difference between that is 2.5, so that's 250%. And both relative risks in terms of times more likely or percentages are both reported in the medical literature. So this is a prospective clinical trial, and therefore relative risk is what's going to be done. Sometimes people will use hazard ratios that mean pretty much the same thing, except hazard implies that there's an adverse kind of thing that you want to avoid. Just as an aside, since we're here, for case control studies, for retrospective studies, odds ratios are used. An odds ratio is a little different. It's the odds or the chance of exposure in those with a disease and those without a disease. And so if you had already done this, you had already noted that people that were on this had a greater chance of ischemic stroke or smaller chance of ischemic stroke, you might do a retrospective case control study, and that would be an odds ratio. You interpret it in a similar fashion. If the odds ratio is 1, it means that the odds are equally likely in those with and without disease. And if it's less than 1, it's less likely. If it's greater than 1, it's more likely. All right, so let's go back to our original one. So remember that I said that I'm going to frame my null hypothesis, and I'm going to accept an error rate, an alpha error rate of 0.05. So that means I can be wrong 95% of the time, 5% of the time, and I would be correct 95% of the time. So if I look at the alpha, or the p-value, and it's greater than 0.05, then it means that there's no statistically significant difference between the two groups. Ischemic stroke in people with taking Pradaxa and ischemic stroke in patients that are taking warfarin. Another way that you could do it is that you could give the confidence interval at the 95th percent confidence limit and look at the range of values. So if I use a relative risk, in this case, odds ratio for the retrospective studies, and if that includes 1, then there's no statistical difference. Because if you remember, in that 1, that meant that we basically had no difference between what I was testing and what I was not testing. So 2 ways that you can look at statistical significance. One is with the p, or the alpha value. The other is with looking at the relative risk and seeing if it includes 1. So let's do an application. In this case, the RELY, which was the trial that was used for the Pradaxa, compared Pradaxa and warfarin in preventing ischemic stroke. This was a study that was done a little bit more than a decade ago and really changed the way that we actually do anticoagulation management for people with atrial fibrillation. And so there were over 18,000 patients enrolled in this trial. They used a CHAD score, which was the earlier precursor to the CHAD-VAS score, and they were given either Pradaxa or warfarin. Of those people taking the 150 milligram dose of Pradaxa, 134 of them had an ischemic stroke, and of those patients that were taking warfarin with their blood level at the appropriate level of thinness, so you have to monitor warfarin using what's called the INR, and that has to be set within a certain range. So this was done, and there were 199 patients that had an ischemic stroke. So the relative risk that was calculated for patients taking 150 milligrams of Pradaxa was 0.67. And the study authors said, okay, the 95th percent confidence interval for this was 0.53 to 0.82, with a p-value of less than 0.001. So if my null hypothesis was that there is no difference in the number of ischemic strokes with patients taking Pradaxa and warfarin, is this null hypothesis supported or refuted by this? Well, I could look at this one of 2 ways. Way number 1 is I could say that the confidence interval at 95th percent does not include 1 for my relative risk, and so therefore it is statistically significant. These are different outcomes. The other way that I could actually do this is I could look at the p-value, and when I look at the p-value, it was less than 0.001, and that's less than the 0.05 that I accept as my error rate. Now, they also, in this trial, used a different dose of Pradaxa, 110 milligrams, and in this group, 182 patients that took the 110 milligrams of Pradaxa, and 199 that we talked about before taking the warfarin had an ischemic stroke. Now the relative risk for this Pradaxa group was 0.91 with a 95th percent confidence interval of 0.74 to 1.11 and a p of less than 0.34. Is this null hypothesis, that is the patients that are taking 110 milligrams of Pradaxa, protected or not protected as well as with warfarin? So now in this case, the confidence interval does include 1 for that relative risk, and the p-value is not less than 0.05, so there's no difference between those distributions of patients, and there is no statistical difference. I cannot reject the null hypothesis. I have to accept that there was no statistically significant difference in stroke, in ischemic stroke, between the patients taking 110 milligrams of Pradaxa and warfarin when it was managed appropriately. All right, so just as an aside, you could calculate this relative risk. There's a very simple formula for actually doing this. You just need the original data. So if I look at those 150 milligram dosed patients, there were 6,076, and there were 6,022 that received warfarin. I had 134 patients taking the 150 milligrams of Pradaxa and 199 taking the warfarin who had an ischemic stroke. The formula for relative risk, if you create a 2x2 table, much like the 2x2 table that we used for diagnostic testing. In this case, I'm going to look at the people that had a stroke and that didn't have a stroke, the people that took Pradaxa, and the people that took warfarin. And I can then use this relative risk calculation in order to do it. Just as an aside, it's a slightly different one, what we call the cross product, this times this, divided by this times this, which is used for odds ratio. So if I go back to my data, I had 134 people in the Pradaxa group and 199 that had a stroke, and that means the people who didn't have a stroke were the 6,076 minus this 134, or the 6,022 minus the 199. If I do this calculation using these, I get my 0.67, which is what was reported in the trial. This is not done really by hand now. This is done with statistical packages, but I wanted you to understand that it's a fairly straightforward calculation for being able to do this. So I hope that this gives some context into understanding and interpreting medical studies, because this is a very important kind of application. And I will see you later for another episode.